Hello everyone and welcome to Chapter 33, Assessment of the Hematologic System. And today we're going to review this system, which is essentially the body's internal transportation and defense system. It's responsible for oxygen delivery, immune defense, and clotting. So if something goes wrong here, it impacts the entire body, right? So as nurses, this assessment is critical because many life-threatening conditions like hemorrhage, clot formation, anemia, and even sepsis show up in the blood work first. So remember, this system is one of the most powerful early warning systems in the body because blood tells the story of what's happening internally. So remember, the life is in the blood. The priority concepts for this chapter is clotting and perfusion. These are not separate concepts. They're very closely connected. Perfusion, as you well know, depends on blood volume and blood flow, and clotting determines whether the blood stays where it belongs. So too little clotting leads to bleeding out. Too much clotting can lead to stroke, PE, MI, and DVT. So hematology is a balancing act. Your patient is either at risk for hemorrhage or thrombosis. So perfusion means blood flow through the tissues. Peripheral perfusion is about the extremities, like the hands, feet, the skin. Central perfusion is the heart's ability to pump blood to the vital organs. Now, clotting is a complex multi-step cascade, and you may remember this from A&P, that cascade of clotting, that protects the body from bleeding to death, right? Clotting is protective, but only when it's controlled. So perfusion is delivery, clotting is protection. The nurse's job is to recognize when either one is failing. So a little A&P review. The bone marrow is the blood cell factory. Everything starts in the bone marrow. The RBCs, WBCs, platelets, etc. So plasma is the liquid portion of the blood, and it carries proteins and clotting factors. The albumin maintains the oncotic pressure. Globulins are immune proteins. And then the fibrinogen and prothrombin are essential for the clotting. So RBCs, oxygen transport via the hemoglobin. The WBCs is immunity and infection defense, and this is stuff you already know, just a good review. Platelets, primary clotting plug. And then the spleen filters old RBCs and supports immune function. The liver produces clotting factors. Hemostasis and blood clotting. Hemostasis is the body's controlled response to vascular injury. The goal is to stop bleeding, but not to create a dangerous clot. Step 1 is vasoconstriction. Tighten vessel to slow the bleeding is what vasoconstriction does. And then platelet aggregation. The platelets stick to the injury site and form a plug. And then the coagulation cascade, this stabilizes that platelet plug with fibrin. There's an intrinsic pathway, which is fast and triggered by the tissue damage, and the intrinsic pathway is slower and it's activated by inside the bloodstream. So platelets start the plug, but clotting factors finish the job. This slide showing the body's clot breakdown system called fibrinolysis. And after a clot forms, the body must break it down so blood flow can return to normal. The key player here is the plasminogen, and the plasminogen is inactive until it gets activated. So then activated plasminogen becomes plasmin. Plasmin is the enzyme that digests the fibrin. Plasmin breaks the fibrin clot into fibrin degradation products, and this prevents excessive clotting and keeps that circulation open. The body's constantly balancing clot formation and clot breakdown because both extremes could kill the patient. So if fibrinolysis is too strong, you got bleeding. If fibrinolysis is too weak, you got clot overload and then risk for stroke or pulmonary embolisms. You will not have to know this cascade. So hematologic changes that are associated with aging. Aging affects blood production and immune function because the blood volume decreases and there's less plasma proteins. The bone marrow becomes less active, so there's fewer blood cells. And then the red blood cell count decreases slightly, so mild anemia they may be at risk for mild anemia. Hemoglobin and hematocrit drop a little bit, and so lymphocytes become less reactive and the immune response weakens. So in older adults, fatigue is not automatically just aging. It could be because they may be starting to become anemic, nutritional deficiency, or even chronic disease. So older adults may not mount strong fever responses, so infection can be subtle. Just something to keep in mind. So assessment. So when assessing these hematologic issues, history is everything. So we're going to ask questions about their immune disorders, liver disease, because remember in the liver there's clotting factor production. Hematologic disorders like anemia, leukemia, hemophilia, things like that. We're going to ask about their history of cancer because chemo suppresses the marrow. Occupation and hobbies. Have they been exposed to chemicals, radiation, and toxins, those kind of things? Drugs, we want to ask them about their medication history because many meds do affect clotting, like aspirin, like we've talked about, NSAIDs and anticoagulants. And then their nutrition, iron, folate, B12 deficiencies show up as anemia. And so family history, some clotting disorders are inherited, like the factor 5 Leiden hemophilia is one of them. So a hematologic assessment is like a detective process. You're kind of looking for the hidden reason the blood's malfunctioning. So recognizing cues on our physical assessment. So we're going to be doing a head-to-toe assessment because this disorder can show up anywhere. So when you look at the skin, you may see pallor, which is indicative of anemia. The petechiae, that reddish purple color, you want to know that word. Bruising can mean a clotting disorder. Head and neck may have bleeding gums. That may indicate thrombocytopenia. You want to know that word. Or leukemia. Respiratory, shortness of breath can signal anemia or PE. Cardiovascular, the tachycardia is a compensation for low oxygen. Kidney and urinary, hematuria may indicate bleeding disorder. Musculoskeletal, bone pain can be leukemia or marrow involvement. Abdominal may suggest increased red blood cell breakdown. CNS, confusion may be hypoxic from anemia. So just doing a really good physical overall assessment. Patients with chronic blood disorders often experience anxiety and fatigue related to depression because blood disorders don't stay in the blood. They affect oxygenation, perfusion, immunity, and even cognition. Recognizing cues continued. Lab work, of course, is the backbone of hematology. So there's three major categories: the cell number and function, that's the CBC with diff. The bleeding and coagulation test is the PT-INR and APTT and platelet function test. And then the blood group and RH, that's critical for transfusions and things like that. So just to reiterate on the PT, that is how long it takes for the blood to clot. So anything greater than 20 seconds is considered critical and needs immediate attention. You want to know that. Recognizing cues continued. You may be doing additional diagnostics, including things like X-ray, CT, or MRI, because this can help determine if blood disorders are affecting organs or bones. May be used in tumors, metastasis, lymph node enlargement. Bone scans detect bone involvement in cancers. And then bone marrow aspiration or biopsy. This is a definitive test where the marrow failure or leukemia may be suspected. Bone marrow aspiration and biopsy is a major diagnostic procedure for leukemia, lymphoma, and anemia and marrow disorders. For patient preparation, provide accurate information and emotional support. Explain the procedure and verify that the informed consent's been obtained. What the procedure will be like. Follow-up care, prevent excessive bleeding, teach to inspect the site every 2 hours for the first 24, and avoid activity that could result in trauma. Another thing that is very important is to check that pressure dressing for signs of active bleeding. You want to know that. Bone marrow biopsy is not just uncomfortable, it can be anxiety producing, so nursing support matters a lot. Lymph node biopsies often performed to diagnose lymphoma or metastatic spread. Some of the methods used is fine needle aspiration, core needle aspiration, or surgical removal. The lymphatic system is the body's immune highway. When nodes enlarge, we biopsy because cancer often travels through the lymph. That's why it's done. So now we're going to apply this chapter through some questions designed to mimic the NCLEX style priority thinking. Question 1. The nurse is caring for an 82-year-old client with progressive fatigue, shortness of breath, and headaches. Which assessment questions will the nurse ask as the priority? Select all that apply. So A is, do you live with anyone? B, have you been depressed lately? C, which medications do you routinely take? D, could you tell me about your dietary habits? Or E, do you have a history of cardiovascular disease? So going back, what the question's asking is, they have progressive fatigue, shortness of breath, and headaches. So which ones would you pick? And it's select all that apply. So the answers C and D. Medication history matters because of the aspirin and NSAIDs that may be causing gastric irritation or any GI bleeding. The dietary habits matter because iron deficiency is common. Social history and cardiovascular history are important, but it's not first priority. So priority assessment is always about what will reveal the most dangerous cause first. Okay, question 2. The nurse is caring for a client with bleeding gums that reports increased fever, fatigue, malaise, and chills. Which intervention will the nurse perform as the priority? A, notify the healthcare provider. B, document assessment findings. C, administer antipyretic drugs as prescribed. Or D, review laboratory data and prepare to obtain blood cultures. The answer is D, and I'm just going to read the slide in case you guys are just listening. The nurse should initially review the client's laboratory analysis for signs of pancytopenia related to the client's report and assessment findings of fatigue, bleeding gums, and chills. Laboratory data are needed before informing the healthcare provider and deciding whether to administer medication. Obtaining blood cultures prior to antibiotic administration is an important intervention. Antipyretic medications may be prescribed to treat the fever and can be given after reviewing the laboratory data and collecting samples for blood cultures. The nurse can notify the healthcare provider and document after other actions are taken. Question 3. A client is being transitioned from IV heparin to oral warfarin. Which laboratory finding will the nurse reference to confirm that warfarin treatment is effective? A, the bleeding time. B, the prothrombin time, the PT. C, the international normalized ratio, the INR. Or D, the partial thromboplastin time, the PTT. The answer is C. It's the INR. The INR is standardized across labs. Therapeutic warfarin range is usually INR between 2 and 3. That's what's considered therapeutic. If an INR is too high, bleeding risk increases, and if an INR is too low, clot risk remains. Warfarin's a narrow therapeutic window drug, so too little doesn't prevent clots and too much causes hemorrhage. That's why usually people who are on warfarin will have to go to the Coumadin clinic, or someone comes to their home, or sometimes they may even have their own monitor now, I think. But they have to check it at least weekly, and the dosages are adjusted based on that 2 to 3 window. The hematologic system is a reflection of perfusion, immunity, and clotting stability, and nursing assessment requires recognizing patterns across symptoms, physical findings, and laboratory trends, as we've talked about. When we identify abnormalities such as anemia, thrombocytopenia, or neutropenia, we can prevent complications like hypoxia, hemorrhage, and life-threatening infection. Hematology is not about memorizing numbers, it's about interpreting what those numbers mean for patient survival. Thank you for listening.